To what I'm going to talk about, which is really thinking about how economic modelling could be incorporated within that design process that Bogda described. And even though I'm going to be using a very different case study, I think you'll be able to think through how what I'm talking about could be applied to Bogda's project as well. So essentially what I'm thinking about is how to incorporate economic modelling in that design process, and both in terms of that stage of defining the problem that Bogda talks about, where we can model current pathways, costs and outcomes, and that can hopefully focus the problem, provide more information to inform the definition of the problem. And I do recognise what Bogda was saying about data and time and costs required with doing that process. So it's really trying to work out what's feasible for individual projects and what's going to add greatest value. And then once you move on to the designing the solution phase, it's around using modelling to estimate the expected costs and benefits or outcomes to inform the design of the solution. So starting where we got to last week, and to where we talked about the PICO and redefining the order of the PICO to an OCP, where we start with the outcome. So this is really in line with what Bogda was talking about in terms of the problem. So what's the problem? What are the outcomes that we're trying to improve? What do we understand? What do we know about current pathways and how those affect or are associated with those outcomes? Then we can define the population and then think about the interventions that would support better outcomes in that population. So the case study I'm going to talk about today, as I say, is hospital-acquired hypoglycemic events. And so the OCP for that case study, the outcome is clearly hospital-acquired hypoglycemic events. To understand current pathways that lead to or associated with these events, we talk about using a clinical audit to inform a model to describe those pathways. That model is then used to define our target populations, and then finally, given our target populations and pathways that we've described, we can undertake an intervention synthesis to design our solution, which would then be piloted as Bogda described. So just to give you an idea of what's involved in this type of project, to run through the outline of the project, we start by creating a working group combining researchers and clinicians on the ground. So for this working group, we included the hospital-acquired complications coordinator, Brianna Reed, here at Saarland. We've got pharmacist, nurse, allied health professional, endocrinologist, as well as Paul Hackendorf, our clinical epidemiologist, and myself and Jody Gray, health economist, health service researchers, who well, I was going to say we're doing the work, but Jody's doing the work. So we work with the working group to develop a novel clinical audit tool, which is designed to elicit information to inform our decision tree. We also developed a literature search strategy, undertook the audit, and the key aim of the audit was to identify events that are associated with the occurrence of hypoglycemic events and use that information to define a decision tree structure. The next stage could come at this point or it could come later, but we took it, the literature review, at an early stage because it just fitted in with the timings that we could do the audit and the literature review simultaneously. If we did it later, it might be a more focused literature review, so that it doesn't have to come at this stage. Then once we've collected the audit data, we estimate our decision, well, we define our decision tree structure and estimate the parameter value, so I'm going to talk through that process. Then we start looking at interventions, initially with the working group, and potentially then taking it out to a broader group. And finally, we analyse the model. So I'm going to talk through those stages now, noting that we're partway through the project. So the first step was to think about the potential events that might be associated with a hypoglycemic event within hospital. And so we've categorized these into 4 broad categories. So the first category is around diabetic medication use, and primarily thinking about timing at which medication use is increased in dosage, so whether that's insulin, an injectable hypoglycemic agent, or an oral hypoglycemic agent. There may be poor synchronization between treatment and meal times, which can lead to hypoglycemic events, or there may be medication errors. So a range of potential medication-related events associated with hypoglycemia. What we're finding from the audit data is that actually the main category associated with hypoglycemic events are nutrition-related. So events where carbohydrate intake is reduced, and that may be due to a range of factors, whether patients are fasting, they've got a reduced appetite due to nausea and vomiting, they've missed a meal or delayed a meal for some reason, they're receiving liquid diets, or there's a change in the mode of feeding. So all of these things can lead to hypoglycemic. And if we can identify the ones that are most commonly associated with hypoglycemia, we can target those with our intervention design. Health status is the third broad category, so patients who are recovering from acute illness or infection or stress may be at greater risk. Experience of hyperkalemia, but in particular increased activity we hypothesized as a potentially important event, so patients commencing rehabilitation, for example. And then finally, thinking about the healthcare that patients are receiving. Has there been a transition in care? We know that spending time in the ICU, and especially on mechanical ventilation, can be a risk factor for hypoglycemia, or discontinuation of particular therapies such as corticosteroids. So with that information, we can start thinking about how we're going to structure our decision tree. And so I'm just providing a few options here just to illustrate the different thought processes you might go through in terms of defining your model structure. So at a very simple level, we might use those 4 broad categories. And so we've got our diabetic inpatient population, and a proportion of that population may fit into, the 3 categories and a none of the above. So here we've just got diabetic medication, nutrition, physical activity, or none of the above. Even if you're none of the above, there's still a probability of experiencing a hypoglycemic event. So here we're describing, given that you're in each of these boxes, what's your probability of a hypoglycemic event? And then if you experience an event, in this case we're using the financial penalties as our endpoints in the decision tree, what level of financial penalty would you incur, but also what are the other costs, length of stay effects, patient outcomes associated with those different outcomes associated with a hypoglycemic event. We could choose to increase the complexity of the model a little bit by including subgroups for each of the broad categories. So for medication, what type of medication were they receiving? For decreased nutrition, what was the events associated or leading to decreased nutrition, which would allow us to target these groups more accurately. So we've got probabilities of the patients with decreased nutrition, and again for each of those subgroups, what's the probability of a hypoglycemic event? But perhaps the most relevant model structure is one that incorporates time. So in the previous model structures, we didn't have any representation of time. So we've got our patients, and clearly individual patients could experience decreased nutrition on multiple occasions. And so here, our model is describing the occurrence of events each day, or on an average day, within Flinders Medical Centre, for example. And so we've again got our diabetic inpatients. We're splitting them up into those that are newly admitted, because we hypothesize that on admission, as patients are adjusting to being in hospital, they're at increased risk of hypoglycemia. So we've got probabilities for those patients. And then for the existing admissions, distinguishing between whether they're in the ICU or not, and if they're not in the ICU, are they experiencing any of those associated events. And so our next task is to populate that model. So I'm just going to illustrate the process that we might go through to populate, to parameterize this model so that we can estimate the effects of intervening at different sections of the decision tree. So our first set of model parameters are what I've called the denominators, which are essentially the numbers of diabetic patients in each of these boxes on an average day in the Salin. And so in words, the parameters we're trying to estimate are the mean number of daily admissions of diabetic patients, mean number of diabetic patients in the ICU. So they're easy, or relatively easy. We can get those numbers from administrative data. The more tricky ones are the daily frequency of patients experiencing an increase in their diabetic medication dose, experiencing decreased nutrition or increased activity. And so this is where the data is a little bit harder to get, but we can start by talking to nurses to get their perspective, their experience on the frequency of these events. And if we feel like we need additional certainty or additional data to inform those parameters, we can go to patient notes and undertake an additional audit of a sample of diabetic patient notes to estimate those parameters. The second set of event probabilities are the event probabilities. So given the population in each of these boxes, and I haven't represented the full model structure, so each of these have got a hyperglycemia, no hyperglycemia branches coming out of them. So what's the probability of experiencing a hyperglycemia given you're in each of these boxes? And that sounds like it might be quite difficult to do, but actually, given that we've done the clinical audit of the hospital-acquired complications and we've estimated the denominators in the first step, it's actually quite easy to estimate these daily probabilities. So we've got probability of an early admission hypoglycemic event given that you're an admitted diabetic patient, probability of hypoglycemia given you've spent a day in the ICU, probability of hypoglycemia given you've increased your dosing, etc. So from the audit of the HAC, patients experiencing a HAC, we've got the proportion of cases that are early admission hypoglycemias, hypoglycemia in the ICU due to increased dosing, etc. So as an illustrative example, from the audit we may find that 60 of the hospital-acquired hypoglycemic cases were in that early admission phase. So as a 0.16, so that's over a 1 year period. So that's a 0.16 probability of an early admission HAC each day within Salin, 60 divided by 365. And from the administrative data, we've estimated that we have on average 10 new diabetic patients admitted each day. So the probability of an early admission hypoglycemic event for admitted diabetic patients is simply 0.16 divided by 10. So that's our probability. And so we can go through that process for each of these daily probabilities to estimate those parameters. Then the final set of parameters for the baseline model are the probabilities of different outcomes given that you've experienced a hypoglycemic event. So the penalty levels, but also costs and patient outcomes and length of stay effects. So to estimate those parameters, the probability of the different financial penalty categories, again, we get straight from the HAC audit data. Costs and consequences, have to be a little bit more creative. So the actual financial penalties, well, they're provided by the Independent Hospital Pricing Authority. To estimate costs incurred within Salin and also additional length of stay associated with hypoglycemic events, we might undertake a case control study. So our cases are patients who've experienced hospital-acquired hypoglycemia, and we identify controls who have the same characteristics as those cases, but they didn't experience a hypoglycemic event. And we look at the differences in costs and length of stay between the cases and the controls. So that gives us an estimate of the cost and length of stay effects. Patient outcomes, so maybe we could look at readmissions, ED presentations, mortality. So those types of outcomes we can again do a case control study. We can look at the literature. What's the literature tell us about the longer term impacts of hospital-acquired hypoglycemic events on patient outcomes? Or we could talk to clinicians. Again, an elicitation approach. So we've got multiple options, obviously with very different resource implications. So we may start with case-based elicitation and progress from there if we feel that that's a valuable thing to do. So, having populated our baseline model, the next stage is to estimate the effects of different intervention options. So here I've put a red rectangle around potential intervention targets. So we could design an intervention that targets new admissions if they're the main source of our hospital-acquired complications. Could target ICU, or we could target non-ICU, and based on these different events associated with hypoglycemic events. So the parameters here that we're trying to estimate are the proportion of prevented hypoglycemic hospital-acquired complications from different interventions in these different groups. So in newly admitted diabetic patients, in ICU, or associated with dosing, nutrition, and activity. And so to do that, we're undertaking literature search. This is just to illustrate that it's a relatively simple search strategy that we've defined. We've got our concepts across the top, so we're interested in studies that report on hypoglycemia in hospital and their evaluations. And so this is a kind of standard set of search terms that you might use to identify those types of studies. So we did the search, we reviewed all of the titles and abstracts, so we identified almost 4,000 titles and abstracts. When we reviewed those, it came down to 147. When we looked at the full papers for those 147, we managed to exclude another 60. So we're left with 87 full papers that are giving us some useful information on the effects of an intervention to prevent hospital-acquired hypoglycemia. So this is Jodie's piece of art. She's a data artist, I like to call her. It's a beautiful thing. And I'm just going to highlight some of the key aspects of this spreadsheet. So on this left-hand side, Jodie's categorized the interventions into the different sorts of interventions. So we've got 7 categories of interventions: service-focused, role expansion, education, etc. Along the top, we've got categories describing the characteristics of both the studies and the interventions that were being evaluated in those studies. So setting, for example, is it based in the ICU? Was it non-ICU? Was it hospital-wide? Eligibility criteria for patients. Did it focus on insulin? And then a whole range of categories describing details of the intervention. So that's the basis for our intervention synthesis. I talked about this briefly in the second seminar, where essentially this is providing different options for how you interpret the evidence. So in order to define your interventions. So one option is just to use the interventions as evaluated, or you can go to another level really, where you're combining different components of those evaluated interventions with or without statistical modeling. So to illustrate the how you might look at the data using the findings from our systematic our literature review, these are the service-focused interventions. So they give you an example of what we mean by service-focused. So, and you can see the range of the different types of interventions. So the big top here, we've got an intervention that focuses on preoperative evaluation and referral preoperatively to a diabetes management team. You've got an on-admission intervention, so as soon as patients are admitted, they have a consult. Then you've got a couple of pharmacist-led teams, the first one coordinating post-surgery glucose control, the other one more general. And then at the bottom, we've got two what are called virtual glucose management service interventions, where pharmacists review electronic medical records remotely and identify patients who they think are at risk and add notes into the medical record for the people doing the ward rounds to be aware of. And then we've got the very high-level summary of the effects, reported effects of those interventions. And so you see that the range from statistically significant reduction in severe cases, which would be probably the best outcome that you'd expect, because you really want to have more of an effect on the severe cases, to no reduction, and everything in between, really. But you also notice that these studies are not just reporting on hyperglycemia, they're reporting on hyperglycemia, or most of them are. So two of them are not reporting, but the others are reporting, and the one that's hidden is probably the best one. So I should, there we go. So you see, yeah, the two at the bottom would really seem to have the strongest evidence when you take both outcomes into account. So that's just a summary of the evidence, but but in order to really make an informed interpretation of the evidence to design your intervention, you really need to consider the costs as well. So clearly there'll be different costs associated with each of those interventions. And especially with the second one, you need to have electronic medical records, which might be a problem right now, but will be resolved next year. So our next step really is to think about, not in any detail, just to provide a crude estimate of the potential costs of implementing these interventions. But we also need to think of the different levels at which these interventions could be implemented. So if we've got a pharmacist-led team, who are they targeting? How many pharmacists would we need to implement that type of intervention? But of course, one of the other consequences of the literature review is that by reporting effects on hyperglycemia as well as hypoglycemia, probably need to go back to the decision tree and expand the decision tree to include hypo as well as hyperglycemia. Otherwise, we're ignoring potentially important benefits associated with those interventions. So I haven't spoken to Jody about that, but that's to put on the to-do list. But that's how we do that will be interesting, because we don't necessarily want to go back and do another clinical audit, but maybe we have to. So it's yes, that'll be something to think about. So that's really my example of the use of modelling, and as I say, is ongoing. I look forward to finishing that and presenting the final results So this slide looks very familiar because it's the same summary slide as last week. So it's just really emphasizing the benefits and potential use of modeling as a framework. And the final bullet point is new in that we are happy to discuss potential modeling projects. This is really our kind of bread and butter, we will really enjoy doing. So always happy to discuss ideas and potential projects that use modeling.
So I'm just going to open up to any questions here, or
Sorry, I put it on the slide over. John, I mean, we'd all love health economics to be part of every clinical study that's ever done, but that doesn't necessarily happen. But if a study's been designed looking at clinical effectiveness and then later down the track they decide that they really should be looking at cost effectiveness as well, is there a point where we say, look, it's really too late, we haven't been capturing all of the data along the way to make really good decisions, or do you think we can always backtrack and pull those pieces of information together?
Good question. Well, my short answer is that I think it's always worth trying to collect economic data, no matter how late you've left it. But clearly, the value of that data will be less if you haven't planned the collection, and it's just going to inform the decisions less than it would do if you'd planned it up front. Yeah.
John, I was fascinated. It might be simple to you, but it's pretty complicated to most of the rest of us. But as you know, blood glucose control in the intensive care has been a headline for probably the last 15, 20 years even. And so I was very pleased when you came back and said, two sides to the coin. We've got hypoglycemia, hyperglycemia. The big Australian-Canadian study that was done in this area found that hypoglycemia was a major problem. But it was often hypoglycemia that I'm not sure would have been a definition that we would have got our coders to push in there as well. So I guess that's an added complexity to that as well. So how do we deal with that, or do we deal with what we've got and recognise the limitations and then come back to it if we need to?
In terms of the coding?
Yes.
So from the clinical audit, I think Jodie can correct me, but there were 6 that were not, so were classified as hospital-acquired hypoglycemia, but were actually, when you looked at the audit, we couldn't work out why they've been classified. So yeah, data is an issue, but the clinical audit will help expose that. The good news from the clinical audit is out of 93 cases we've looked at so far, only 1 was in the ICU. But good news for you anyway.
Well, maybe, but maybe we'd go back to the ICU and even have a look there, because I think that blood glucoses that we wouldn't have, I think it was, glucoses of 3 and 4 were associated with increased mortality risk in those data. So that's maybe it's another component to look at that as well.
Yeah.
But that was fantastic work. I think we'll be very interested to see what you find, Jodie. That's great. Thank you very much for that. If there's no more questions, we'll hold our breath until 2 weeks' time.
Oh, yeah.
And our virtual audience would love to hear some feedback as well. That would be great. Some of us would like to do this in a continued and maybe varied format with a few other ideas as well next year. So we'd love to hear about that as well and see if you've got some support for that. So thanks very much. See you in 2 weeks.